Hello, I'm Dr. Joey, and today we're going to discuss one of my favorite subjects, fungi. Okay, you know what? I tried. The reality of it all is fungi just are not sexy to most people, even if I want them to be, because I like them. But you may want to at least hear me out today as I talk about this particular species of fungus, because this is a serious situation that could be developing here. In fact, the CDC has rang the alarm twice now, but no one seems to be listening. And what I'm discussing is Candida auris, which seems to be a new species of Candida that we're not really sure its origins or even how long it's been with us. But what we can agree on, almost unanimously, is that it seems the pandemic, with its increased use of steroids, albeit warranted, has been exacerbating an already bad situation, because this fungus seems to be spreading at an alarming rate, and it seems to be drug resistant to all other antifungal types that we have. Until this particular stock came along. That stock is ticker symbol SCYX. The name is Scynexis. And it has just gotten approved by the FDA, a brand new class of antifungal drug, the first of its kind and the first new type of antifungal in 20 years to be approved, and it seems to be the antidote to this particular species of Candida, as well as many other forms of fungi. Stay with me a little while and explore this, if you will, because I think that you're going to like what I have to say. On this channel, we like to discuss things that are a little bit of health, a little bit of wealth, and a little of everything else. I'm Dr. Joey, and if this is your first time visiting, welcome. But if it's not, well, welcome back. Please remember to like, share, and subscribe this video, as well as any others that you may see on this channel. That's all I've got for now on the intro. So without further ado, let's get it. So just quickly, I want to show the difference that all of the items under living there are considered living organisms by scientific terms, by scientific definition. Therefore, a virus is not considered a living entity according to science. Now I would like to show you on the screen how at the top picture there, you will see the green item is just displaying for you that is a plant cell, and it has a cell wall that is comprised of cellulose. We cannot digest cellulose. This is why when we eat very green chlorophyll-y things with a lot of cellulose still in them, such as celery, we cannot digest that, and it comes out as fiber. All right. But when it comes to animal cells, which we have, of course, we have a biphospholipid membrane. It is a cell membrane that is comprised of a phospholipid bilayer, all right, and it is polarized, and that allows things to come in and out across the membrane. Now, when we look at the bottom photo there, that is a fungal cell wall. You will notice that it has a cell wall that is sandwiched between two cell membranes. Now, it depends on the type of fungus, because like bacteria, different fungi have different compositions of their cellular structures, as well as far as like the integrity and what holds them together. This is showing you two different views of two different fungal species. All right, but the thing that is common is that in their cell walls, it is not comprised of cellulose. It is comprised of glucans and chitin. Chitin is the same thing that's on insect exoskeletons for any entomologists out there. Now, somebody will inevitably say, but Joey, don't bacteria have cell walls? Yes, they do, but theirs is composed of peptidoglycan, all right, and that's made by polysaccharide cross-linking, whereas bacterial cell walls, they are not composed of cellulose like plant cells, nor are they composed of chitin and glucans like fungal cell walls are. But animal cells, of course, have no cell walls. They have a phospholipid bilayer. Now, this comes into play because when you're trying to treat a bacterial infection, for instance, if you give a medicine that is specific for cell membrane to break down the integrity of the cell membrane, then that's bad because you're going to be hurting your own cells because we have cell membranes. If you're attacking a bacteria, though, that has a cell wall and you give an antifungal medicine, that's bad because that antifungal medicine is specifically targeting the chitin or the glucans that are inside the fungal cell walls. Therefore, it will not touch the peptidoglycan polysaccharide chains that are within the bacterial cell walls. But when you want to destroy a cell wall that has cellulose in it, then obviously an antifungal won't work for that either. So as you can see, it really gets tricky depending on what you give. This is the same principle on why people lose their hair when they are on chemotherapy and cancers. Over the course of our lives, and let me just come on the screen for this. So over the course of our lives, we continue to grow and proliferate and generate new cells in certain areas only. As an adult, most of our cells, you've had all the cells you're going to have that have grown. For instance, muscle cells, they don't grow new muscle cells. That stops about the age of 12 or 13. As you build muscle when you get older, you are actually just working with the cells you already have and recruiting new muscle cells, all right? And they are going to get stronger. But when you're before the ages of that, you actually will grow new muscle cells as well as recruit and make stronger the already present muscle cells. Now, the areas that do continue generating new cells are going to be our skin, our hair, where else? Let's see, our skin, our hair, our stomach, like the interstitial lining of the stomach. So for this reason, when you give an anti-neoplastic drug, aka some types of chemotherapies, okay, a tumor by definition is an unchecked growth that continues growing and then metastasizes, breaks free, goes throughout your bloodstream, okay, and lodges itself in other areas and continues growing. Anti-neoplastics are going to stop growth, usually by stopping some part of the mitotic cell division. Now, when you give an anti-neoplastic, you're going to stop that tumor growth, but you're also going to affect your own body's cell growth in areas where it continues growing new cells the rest of your life, such as your hair. Therefore, you don't grow new hair, and your hair you have falls out. Your stomach cells. This is the reason why chemotherapy makes people horrendously weak and weak-stomached, where you can't really stomach a lot of things, all right, for digestion. And it also affects the skin, makes the skin extremely permeable and thin, almost translucent on some patients. Antifungal innovation is lacking for hospital fungal infections. This is true, and there are 3 classes of antifungal drugs specifically. Once we get beyond those 3 classes, if one of those do not work for a fungal infection, we actually have to go towards anti-neoplastics, or aka cancer drugs and things of that nature, especially when it's a systemic fungal infection. The 3 classes of drugs are polyenes, azoles, and echinocandins. And you will notice quickly at this chart that is on the screen that what may work for one drug, the fungus being susceptible to one type of drug like a polyene, it may not be susceptible to an azole, okay? And a lot of this, it depends on the location of the fungal infection. For instance, if you have a normal yeast infection, we typically will give something like miconazole, right? And that's going to be the cream that you'll thickly lather up down there and put topically and spread around. But if you have candidemia, all right, which is candida in your bloodstream, then you're going to have to give something more potent and something that you can give intravenously that will circulate in your system. Most fungi are susceptible to only one type of those 3 drugs, 2 at most, and that's if you're lucky, okay? But a lot of them are starting to show resistance now, and when you only have one type that is effective anyway for that fungus, and then the fungus starts to show resistance, now we're in trouble. This is where we're heading towards, and where we have been heading towards for some time now. This is why Brexafemme, aka the Ibrexafungerp, or however you pronounce that, I forgot to ask them that when I talked with them the other day, but this is why this is so important at this particular time, in this particular moment, while we're seeing the uprising of even a new species of Candida that is drug resistant now. These are just antifungal drugs here. There's 3 types as I've showed you previously, but this just breaks them up a little more. For instance, the azoles, it broke them up into imidazoles and triazoles. It also has a group called others over there. That's going to have like drugs like griseofulvin, which is actually going to affect mitotic spindles, like I was saying. It breaks up some portion of mitosis and new cell regeneration, as I mentioned earlier, for a lot of cancer drugs. But the main thing I have this chart on here for is I wanted to pay attention here for the azoles, and this one in particular, ketoconazole, and how it works. It inhibits the cytochrome P450. Cytochrome P450 is extremely important as an enzyme, as it is what processes many things in your liver. So if you have a systemic fungal infection and you give ketoconazole, all right, which it is the standard of care for certain systemic infections. If you give that, though, you have to be careful. Let's say that your patient is on hydrocodone for pain killing, okay? Hydrocodone is broken down by cytochrome P450. So if you give ketoconazole, that patient now has pain killer that is not able to degrade or break down in their liver, all right, because that enzyme that does that is inhibited. So now you're going to develop hepatotoxicity or toxicity in your liver. And this is the problem we have with our current antifungal medicines that we have. So we're in desperate need for a fungal medicine that is well tolerated, all right, by humans, that does not really interfere with other drugs, has a good safety profile, and is extremely effective on a broad spectrum level, so it can take care of all these types of fungi that we're starting to see now that have some type of drug resistance. This here is just showing how also when you're dealing with antifungal drugs, not only do you have to make sure that you are getting the right one that is acceptable, the right drug that for which the fungus you're treating is susceptible to it, but also you have to look and see what are the routes of administration. For instance, as I've said, there may be an azole that is good topically as a cream to destroy a fungus on the outside of your body, but what if that same fungus, Candida, is inside your bloodstream? You can't give that same azole. You have to move to something different that's going to work systemically. Not only do we have to worry about that, though, but we also have to worry about the routes of elimination, because if you have a diabetic patient, or if you have a patient who already has kidney failure or kidney disease of some type, and you give them an antifungal that is extremely hard on the kidneys and it's eliminated by the kidneys, you're going to totally destroy this person and take them to a new level of chronic kidney disease, all right? So we have to factor in all these different things when you're treating fungi. As I told you, fungi are living organisms. If you thought the viruses have been mutating at a rapid pace and doing crazy things like this coronavirus, that's hiding its spikes and then exhibiting the spikes in different manners and different, relocations of them on their topography, then imagine what something that is a living entity can do once it starts mutating. Again, this just lets you know that we need something well tolerated with good compliance. Okay, that's another thing, is when we get into compliance. For instance, as a physician, if I'm going to, let's say I prescribe an antifungal that is a 14-day course pill that you have to take twice per day. The chances of my patient taking this same pill twice per day at the right times for 14 days in a row, very little compliance, right? Versus something that can be given intravenously on a 2-day course in the hospital. Okay, we have a staff of nurses that are going to give it at the right time, and the patient is there, so you know the patient is getting it adequately, and voila, hopefully the fungus be gone, right? But if you have something that the patient has to do by themselves, the longer that extent of treatment, then the lower the compliance will be typically. So we need something that you can take as a pill that you can take for just a short course also, right? This is what I mean by something with a high compliance. And that's just an excerpt there talking about the successful phase 3 from the VANISH clinical trials. By the way, in the small clinical trial also, it seems that this drug Brexafemme is extremely potent against the Candida auris. But Brexafemme is going to attack the fungi in a new way. That's why it is a novel first-in-class drug. The first one like this, that's bringing something new and innovative in over 20 plus years on the antifungal scale. Okay, I put this on here because I just like people to know that I'm not lying when I say that I'm not vocal enough probably about some of the stocks I pick, but I've tried to be. And for those of you who have followed me on any social media or also in some of the message boards I post in, you will recognize that I have mentioned about this drug several times 6 months ago or more. This is where someone asked a question, since it's an antifungal, could it be used for something like athlete's foot? Well, yes, it would, and it would work very good for athlete's foot, but the problem is you don't want to use it for something as common as athletic foot, because then you're going to start getting resistance that starts to show in that fungal species, which is exactly the boat we're in now that we're trying to get out of. So you want to reserve this. This is like the Desert Eagle, 50 cal that you're going to have in the back of your pants for the final straw. It's like the big boom that you pull out, right? When all else fails. Well, if you pull that out too much, you show your hands too much, then the enemy starts to develop a defense against it, and then it defeats the whole purpose in having the big boom, right? So you want to save this for specific situations, at this moment at least. Now, when it comes to this, the thing that makes it so special, as I elaborated also here on Yahoo message boards, is that this operates as a glucan synthase inhibitor. That means ideally it should work against almost every fungal species except for Cryptococci, Zygomyces, and the Blastomyces. Those are the only fungal species, at least in my knowledge anyway, that is not composed of that beta glucan, that glucan and chitin mixture that I talked about for the fungal cell walls. So the opportunities for this drug are really almost priceless. Scynexis, all right, this is the company that has created this lead drug of Brexafemme, and it recently got FDA approved for vulvovaginal candidiasis. All right, vulvovaginal candidiasis, it was genius to go for this because, all right, what is the most common ailment that humans will experience in their life? It's actually going to be low back pain. At some point in everyone's life, 75 to 80% of us will go to the doctor with low back pain. Let's look at women. What is something that they will experience to that same percentage amount? It's actually going to be vulvovaginal candidiasis, all right? It's going to cause excruciating pain and itching and burning sometimes, and 75% of women in childbearing age will experience VVC. Now, you're also going to have it experienced in about 60% of women before the age of 25. And most of women who experience VVC will have repeat experiences as well. It's like potato chips. You can't have just one. For some reason, it repeats. Again, this is desperately needed because if what we have now, this present form of Candida, started to show resistance, we were going to be up the creek without a paddle, as they say, right? Also, another thing is that Candida is already showing such agility, if you will, and tenacity. For instance, the normal vaginal pH is around 4.5, right? And so what happens is when a woman's pH changes for any particular reason, when it goes, let's say, from 4.5 to around 5.2, then Candida is going to exhibit itself as a budding yeast. But then once you go over 5.2, it starts to form a hyphus form, like a hyphae, and spread out and kind of have a root-like structure about it and qualities, right? And the way that it grows. I mean, it just shows the tenacity that is inherent in it. And now with this new species, the Candida auris, that we don't know its origins or how long it's been with us, and we're learning how resistant it is now, this can get very scary very quickly. Again, just to reiterate, Brexafemme is the first approved drug that is a non-azole class for VVC, and the first novel antifungal class in the past 20 plus years. The drug actually has an estimated market regulatory exclusivity patent protection until 2035. Management is genius. We're going to go over their leadership in just a little bit, okay? But their financial position for SCYX also has an adequate cash runway to last it for quite a while for its continuing its current studies, and then once this already FDA approved drug really gets out there in this post-pandemic time that we are going to head to inevitably, it's going to have tremendous upside potential. And the reason I say post-pandemic times is because steroid use, right? We've had to, albeit, it's warranted that we've had to use steroids so much, dexamethasone in particular, during these pandemic times. The problem with it is steroid use is going to increase blood sugar levels, and that's prime breeding grounds for fungi. Furthermore, steroid use, as you increase it, it's going to actually increase the thinning of the skin. And so, again, we're just setting up breeding grounds for something like what we've seen, the black fungus, the mucormycosis, right? That's happened over in India in particular, and there's been a huge outbreak in that. We're talking about something that you have like a 50% mortality rate once it takes hold. These things are scary, but we have the answer right here, all right? Brexafemme. FDA has granted it ODD, which is, that's going to stand for Orphan Drug Designation for invasive aspergillosis as well as invasive Candida. It's also been granted recently, all right, this month, the European Medical Agency gave it ODD for invasive Candida. FDA has granted it QIDP for the pill and the IV form of SCY-078. That's just the code name for Brexafemme, same thing. The Patent Office has given it 14 years of patent protection, so that gives it market exclusivity to 2035. Some people may not understand how big of a deal orphan drug designation is. It alone gives you 7 years marketing exclusivity on orphan products, okay? Plus, that should say at least 25% federal tax credit for expenses, not just 25%, because depending on when it got approved, that number can go up to 50% actual for tax credit, all right? You get a waiver of the PDUFA fees. That is huge. That alone is a value of almost $3 million. Look, altogether here, the package, the benefit package, if you have to put a price estimate now, it's around anywhere from $3.5 to $4 million total that you can imagine. Basically, you just got to check for that if you're the drug company, because it's money you either get to save or would have had to pay otherwise, all right? But now you get to keep that money, or you get credits for it, which is like free money. Now, don't get it wrong, all right? It's orphan drug designation for a reason. And here's the thing. It was an act that was started in 1983 for orphan drug designation. This means you can qualify in one of two ways. The first way is you're treating a disease that is so rare that it affects under 200,000 people per year in the United States. All right. The second way is if you're treating a disease that affects more than 200,000 people per year in the United States, but there's no logical reason to think you're going to actually recover the expenses that you incurred during research and development of the drug, then it can qualify for ODD status in that way as well. Now, just because it's a rare drug does not mean you don't make money. As we can see here, yeah, they're rare drugs and rare conditions, but there's an estimated 30 million people in the U.S. who suffer from 7,000 rare diseases, all right? So 95% of these diseases have no treatment or cure. So when you look at it, yeah, there are multiple rare diseases, but there's a lot of people who are suffering with these rare diseases. And is it still profitable to seek this path, this niche of pharmaceuticals? Of course. Alexion's orphan drug program alone made them $3 billion in 2018, and Vertex's ODD drug garners them almost $400,000 per patient. Now, the genius in the leadership is this. They know how to add. They know how to stack, right? So you have 7 years market exclusivity for the ODD, all right? And they have multiple ODDs. So that's 7 years market exclusivity for each of those drugs. Then they got QIDP with the this Brexafemme, right? So that stacks on top an additional 5 years. Then there's evergreening processes. What do I mean by that? Often there's this practice in pharmaceutical companies where you come out with a pill form of something. All right, and so let's say you have protections on that for 7 years. But then 3 years into the program, you come out with this new form that's IV for it. Now you get protection on that, let's say for 7 years. Then you come out with a transdermal form of it. So if you see, what we're doing is we're stacking and we're increasing with that patent process for forming the drug in a different manner, plus the trademarked name gives us a certain exclusivity for that, all right? And even if someone like Teva Pharmaceuticals or Dr. Reddy's Laboratory comes along to make a generic form of it later, you already have name brand product recognition with the physicians and with the hospitals and with the patients, the people, right? Like, there's a lot of bandage companies, but sometimes we just call it a Band-Aid, right? That's a brand, right? So you see how those things can kind of take root in our psyche? That's the first in line benefits that you get, or the first to market benefits that you can get. Furthermore, even if a generic brand wants to come and create the pill form and you've already moved to the IV form, you're still creating the pill form. And you can start packaging deals where, yeah, the hospital's buying this new IV form from you because it needs it. It's going to go ahead and buy the pill form from you also, of course. Again, first to market benefits. Now, not only that, but their strategy is genius, all right? So they developed 2 different forms of the drug, of course. And although ODD was already approved for IC, which is invasive candidiasis and invasive aspergillosis, they went for something as common as VVC. I say VCC there, but it should be VVC, excuse me. But that was genius, right? Because they blocked it off. They've blocked off the market because they've got IC and IA in their back pockets now to work with that. They have time to work with it because that market exclusivity starts once you get FDA approved for the drug for that particular condition. And once that drug is approved to go to market is when your time limit starts. But you are guaranteed 7 years market exclusivity once you get to market. They're practical. The management is very practical. It's an all-star team. All right, they went after arguably the second most common cause of human ailment. Like I said, after low back pain, when we look at just the women demographics, 75 to 80% of women during childbearing age will experience VVC at some point in their life. There's many precipitating factors. Women who are diabetic or have HIV or endocrine disorders, those things affect the pH balance. And anything that does that is breeding grounds for Candida. Quick facts about VVC. I think we've gone over most of this. Is VVC harmful? All right, this is a great question because we talk about it as if it's benign so much, but not only the uncomfort that it causes is the problem, but also we forget that Candida is an opportunistic pathogen. So that means if you already have a predisposing issue and then you get it, you could be in some serious trouble. This is just showing, as I told you, there are different forms it can take. Under a pH of 5.2, it typically is an abutting yeast form. Above that, it goes to the hyphus form. You can also have the pseudohyphae form that's kind of a mixture in between, as you see. Now let's briefly talk about the game plan, okay? Because Scynexis is planning to move on from just dealing with VVC to go into invasive Candida, including candidemia, which is infection of the blood with Candida. And when it comes to invasive Candida, all right, blacks in the U.S. at least are 2 times more likely to get it. The average cost of treating this is 3 to 13 days in the hospital, all right, plus $6,000 to $30,000 total care costs, and it has a mortality rate of 25%. After they tackle this, they plan to go to aspergillosis. This has a 50% mortality rate and affects up to 15% of people with cystic fibrosis. In fact, it only has a 1-year survival rate for 25%, 1 year survival rate of only 25% for stem cell patients. And if you have a organ transplant and you contract this, then your 1 year survival rate is 59%. These are not good numbers, obviously. There's great need that is out there for something to tackle these kind of fungal infections. Mucormycosis, all right? You have this, rhizopus, you've heard about the black fungus. Like I said, that's kind of a generic name out there, but this is very serious. 50% mortality rate. So you have a huge upswing in this from increased steroid usage during the pandemic. And for the half that survive, the quality of life is often severely compromised. Scariest news of this pandemic might not be about the actual virus causing the pandemic, but it just might be that we have an endemic quickly working its way to the surface, and that is this Candida auris. In June 2021, the CDC issued an urgent warning about it. Again, in July 2021, New York Times has said they've tried to investigate it, but it's as if nobody wants to talk about it. Chicago Times has echoed that and saying that, like, the silence is scary coming from the hospitals. We expect the hospitals and the clinicians to be able to tell us about these things. Many of them are not able to even track it because they don't know what they're looking at when they see it. How many times has someone died from Candida auris, secondary infection, when they were just listed as COVID-19? Just to put this out there for people who have not watched my videos for Relief Therapeutics or the ones titled COVID-19, from A to Z Sammy, it might be worth your time to watch it, because COVID-19 itself is just a constellation of symptoms that someone has. That's the disease, right? But you die of a secondary infection of some type. It's like HIV, human immunodeficiency virus, right? It's the virus that then eventually can cause AIDS, that's the acquired immune deficiency syndrome. It's a syndrome then that you have a deficient immune system. So now something as simple as cat feces or pigeon poop can take you out of this world, right? Because you get a cryptococcal infection, or you get meningitis, or you get toxoplasmosis from the cat poop. Like, any little thing, like a common cold, can take you out of here then. And so this is the danger of COVID-19, and also the danger of something that's an opportunistic pathogen like Candida auris, which means it takes the opportunity. It can be lurking in your blood and under the system, and you don't detect it or know it, and your clinician does not know it. But once you get COVID-19, then you know it, but a little too late, and it might not be anything to do about it if it were not for Brexafemme being on the brink now. So in other words, the perfect storm is developing. We're starting to see antifungal resistance at an all-time high. This new species of Candida auris is rapidly making its presence known, and it is particularly antifungal resistant. Again, to remind you, there's only 3 types of antifungals that exist. Some fungal species are naturally resistant to antifungal treatment, such as aspergillus. We know that this is susceptible, though, to Brexafemme. Here are some scary statistics about Candida auris. It's drug resistant. The threat level is urgent. This is all from the CDC, okay? In 2018, there were already 323 cases docked. And again, remember that many clinicians don't know what the heck they're looking at or how to even diagnose this, unfortunately. And the typical symptoms you present with, right, they're going to be so vague, you're not going to think fungal infection at first. There's 90% isolates are resistant to at least one antifungal. And you only have 3 types, don't forget. All right? 30% of the isolates are resistant to at least 2 antifungals. But in 2018, it increased in 318%. When we first noticed it, 2015 to 2017, it went up 318%. We don't know how high it is now, but in the aftermath, this is what many of us are worrying about. Look, I know, I'm the weird guy standing in the corner, just some random guy, Dr. Joey, who's, beating his chest saying, hey guys, fungus. And everyone's like, yeah, what about it? But I'm not alone in this. You're going to see that there are a lot other people who are starting to worry about this. This is a serious concern. And in Brazil, they've already reached out because they're starting to notice that it's really taking hold and it's spreading not just human to human contact, but also by surface to human contact. This thing is able to live on surfaces for some time, and there's still so little research about it and so little attention that has been given to it yet. This chart just shows you what has caused antifungal resistance. Now, one thing that's a possibility, I'm not saying it will be or that they're going to work toward this, but it is a possibility that we could see this being used as a fungicide. Fungicide is one of the things that has caused antifungal resistance or contributed to it. Remember I told you, though, that Brexafemme, it will not attack the cellulose plant walls as far as we know. It's going after the glucan synthase and then the chitin walls, which are in fungi. Therefore, this should be safe to spread on plants to kill fungal growth, but not affect the plants, not stunt their growth, right? We know that we need fungicides because one of the things in the Salem witch trial days, right, were people being high on ergot sterols from the wheat. And so the same line, or in the same context of thinking, we try to kill the fungi, but not harm the plants. Now this here is just talking about the complications that can exist. Aspergillus being resistant naturally as it is a mold that then can take root and cause aspergillosis and be deadly. As I said, it has a high mortality rate, and people with cystic fibrosis, they cannot produce, they have a deficiency in their chloride channels. They cannot produce the total combinations that they need to help break down their mucus, and this is just the type of prime category of patient or demographic that aspergillosis is particularly dangerous in. But I just want to say for a moment that, again, if you thought viruses are bad at being able to evade our attempts at killing it, fungi have all sorts of tricks up their sleeves. They are a living organism. For instance, imagine that you're in war as a fighter pilot and you shoot out a heat-seeking missile. What is the other plane going to do? Oftentimes they're going to release flares, right? Heat flares, because that's going to divert your missile from going to their plane, and it's going to divert it towards the flares that they've dropped. Fungi do something very similar. All right, they're going to just upregulate, for instance, the target that you're going after. If you're going after a particular target, then they're going to upregulate that and make a big ball of it, basically, and shove it to the side so that all of your attempts are futile, because they're going to go attack that big ball of upregulated target cells that they just created. Another thing they have is an efflux pump. This stuff is unbelievably sophisticated if you think about it. So you're sending all of these bullets to it, and it basically has created a mechanism or channel that it can pump it out and divert it once again. Another thing it's done is it's just started creating an alternate material. Imagine if there's something that's as strong as steel, and with the steel prices being high right now, you say, okay, no problem. I'll just start making my items out of this alternate product that's just as good. Now what happens if someone comes to destroy all the steel in the world? You're unharmed, you're untouched, you're undetected, right? This is what they have done. Fungi are very smart. We won't get into the finances too much on this particular video, because this is just my first video on this, and if you notice anything on my past videos, I like to do series, but because I like to give each stock, its proper amount of time. But what I wanted to show you here is that the assets being at 109 there, all right, and the total liabilities being at 72, this company does have a nice cash padding, a very nice runway, and they are already FDA approved. I did talk to a representative from over there on the phone yesterday, and she assured me that yes, this is getting shipped out in pharmacies and at hospitals and small clinics everywhere right now. So they're doing a campaign right now to get the word out, and let me tell you, It's obviously working because it has caught the attention of some big name investors. If you look at this here, 49 institutional investors they've already accumulated, all right? You see Scion Asset Management there? Yeah, you know who's in charge of that, right? Dr. Michael Burry. Dr. Michael Burry, all right, he's the guy who called the 2008-2009 housing bubble before it popped. And thus the movie The Big Short, right? That's kind of the plot line of it. He has recently dumped a lot of stocks that they own, but he has bought ravishly for 3 of them, and this is one of the 3. Already, SCYX, 66% of its shares, of its outstanding shares, are held by institutions. 66% of their shares are already being held by institutional investors. You think they don't know something? That's it for this video on SCYX. I hope you've enjoyed your time with me, and please remember to like, share, and subscribe the video. Now, there are 4 particular bio stocks that I am loving right now, and I am just buying, okay? SCYX is one of them. RLFTF, which is Relief Therapeutics, is another. ACER Therapeutics is the third, and number 4 is BABYF, which is Else Nutrition. That's it for this video. I'm Dr. Joey. Thank you for your time, and we'll see you next time.